further evaluation of IBD, you are thinking in this direction, your starting point is most likely going to be the endoscopic evaluation. Right? The barium studies and all are not that commonly performed, so you probably refer it to a gastroenterologist, and he will do a limited or a detailed colonoscopy, or maybe a sigmoidoscopy, and then he will take it forward from there if required into a complete colonoscopy. Now, when we do the colonoscopy, what are the findings that we are expecting? Okay. Now, do we see ulcers in ulcerative colitis and Crohn's disease when we see the mucosa? The answer is yes. Okay. So the pathogenesis of the IBD progresses in subtle stages. So in ulcerative colitis, when you initially do endoscopy, right, you may or may not see ulcers. What you initially see is, when you actually see the real images of normal patients, the colonoscopy, you will see that the vasculature is visible through the mucosa. That loss of vascularity starts becoming evident. But as the disease is much more progressed, what you will notice is that there are development of ulcers. Now, in ulcerative colitis, these ulcers are very superficial. Okay. So when you take biopsy of these ulcerative colitis patients' colon section, you will notice that the pathology is only restricted to lamina propria. It is only restricted to mucosa and a little bit of submucosa, not beyond that. It is not transmural. The entire thickness of the bowel is not affected in case of ulcerative colitis. So obviously the ulcers here are going to be very, very superficial, right? The ulcers are going to be superficial. And the second thing is, because there is mucosal edema, inflammation is restricted to mucosa and submucosa. So there is mucosal edema. This mucosal edema and the death of mucosal cells and a regenerative process. So put those things together, edema of the mucosa and a regenerative process. This leads to formation of inflammatory outpouches, which look like polyps, though they are not true polyps. So we call them as pseudopolyps. So pseudopolyps are more characteristically associated with ulcerative colitis. Does that mean that we never see pseudopolyps in case of Crohn's disease? Not exactly. But whenever you see pseudopolyps, you're more or less dealing with a case of ulcerative colitis. Okay. On the other hand, when you look at the Crohn's disease, there are ulcers, but those ulcers are much more deep-seated, because the process, the pathogenic process of Crohn's disease involves the entire thickness of the bowel. So the ulcers are not only restricted to the mucosa, but they're deep-seated. You can call them as aphthous ulcers. There may be ulcers which are running a snake-like course. So you can call them as serpiginous ulcers. So that's what you might find on the colonoscopy. Right? That's the first point. And second, these changes, right, the loss of mucosal vascularity in case of ulcerative colitis and development of the pseudopolyps and superficial ulcers, all these pathophysiological changes, they, in terms of extent, are continuous. Like affected segment of the bowel. I'll tell you what is the affected segment of the bowel, but that affected segment of the bowel, the involvement is continuous. There are no skip areas or patchy areas where it is involved and patchy areas where it is not involved in case of ulcerative colitis. So that is very, very important. Now going forward, this will also help us to make radiological diagnosis. Because if you have a radiological evidence to say that the mucosa or the bowel is continuously involved, then it is most likely ulcerative colitis, right? On the other hand, the Crohn's disease, the pathology is segmental. So there is some segment of the bowel where the inflammation is there and you see all those classical changes, followed by a segment of the bowel where those changes are not there. There is no pathology there. It looks all normal. And then you have another area where you have those changes. So you call them as segmental involvement with skip lesions. Now the problem comes here is that when you have a patient of ulcerative colitis who has been treated with medications, right, that patient may not have continuous involvement because the regeneration and healing might occur patchy. The pathology was non-patchy, continuous, but after treatment, the regeneration may be patchy, so it might look or it might confuse you with Crohn's disease. So whenever you're doing endoscopic evaluation of a IBD who is already on treatment, it does bring a lot of challenges to the endoscopist. Okay. Then comes the involvement of the bowel, right? Extent we have discussed, but to what extent, like the entire segment of bowel is involved or only a particular segment of the bowel is involved. Now look at the name of the diseases, ulcerative colitis. We're not calling it as ulcerative disease, we're calling it as ulcerative colitis. And Crohn's disease, you do hear the term Crohn's colitis, which is restricted. The use of term is restricted when it is involving colonus only. On the other hand, generally we use the Crohn's disease, right? So that means Crohn's disease is a more extensively involving the gut. On the other hand, ulcerative colitis, it is restricted. The pathology is restricted to the colon, right? So whenever you talk about ulcerative colitis, it is restricted to colon. Generally does not involve small bowel. No involvement of small bowel. That's the point we need to remember. So your ileum, jejunum is not expected to be involved. So if question is asking you whether ileum is involved in ulcerative colitis, open answer is no, but you should also be aware about something called as backwash ileitis. Now, what is this? In around 15% of the patients of ulcerative colitis, like if this is your large bowel, right, and this is where it is entering into the terminal ileum is getting converted here to the large bowel. This is your rectum. Now we all understand that the disease of ulcerative colitis begins in the rectum, right, and then it progresses proximally, right. But in largely it is going to be restricted to the colon. Some cases you might see some degree of inflammatory changes which has no clinical consequence at the terminal ileum. At terminal ileum, there is some degree of involvement. This is what we call as backwash ileitis. Hypothesis behind this is that the inflammatory cytokines which are released into the colon lumen, which is actually affected by the disease, might escape into the terminal ileum to some extent, and they might cause superficial inflammation without any major consequences of that. Whether ileum is involved or not makes no difference to the clinical management of the patient. It has no bearing on the outcome. And this is what we call as backwash ileitis. It is seen in up to how many percentage of the patient of ulcerative colitis? It is seen in around 15% of patients of ulcerative colitis. Okay, but otherwise, ileal involvement is not known to occur, right? So when ileum is not involved, and because the ulcerative colitis always it's a continuous process, without ileum involving jejunum or duodenum or stomach or esophageal involvement is impossible. So in ulcerative colitis, if ileum is not involved, obviously the other components are not going to be involved. In other words, again, I can say ulcerative colitis is restricted to the large bowel or colon. On the other hand, Crohn's disease can affect any part of the gut, starting from oral cavity to the rectum. Though the rectal involvement is not very common, it can. So it can affect any part of the gut, right? Starting from the oral cavity. Now you may ask, sir, there are books which say that oral cavity in ulcerative colitis patients, you might develop aphthous ulcers in the oral cavity. Yes, but the biopsy of the aphthous ulcers in case of the ulcerative colitis of the oral cavity does not resemble the biopsy findings of the colon. So it is just, I can say it's an extra-intestinal manifestation when you develop aphthous ulcers in ulcerative colitis. But when you develop ulcerative changes in case of Crohn's disease in oral cavity, it is not an extra-intestinal manifestation, it is part and parcel of Crohn's disease, right? Okay, so ileal involvement, generally not seen. 15% of ulcerative colitis, you might have backwash ileitis. But in Crohn's disease, 3/4 of the patients generally have terminal ileum involvement. Okay, now coming to the rectal involvement. As I've already told you, rectum is where the pathology begins in case of ulcerative colitis. So the most commonly affected site in case of ulcerative colitis would be the one where the process started. So obviously that's going to be rectum. So it is most commonly involved. Now in case of Crohn's disease, there's no hard and fast rule to say that there should be no involvement of the rectum, right? It can be involved in around 10 to 15% of the patients, rectum may be involved, but largely speaking, it is spared, right? So traditional MCQs do talk about this, rectal sparing, Crohn's disease, rectal involvement, ulcerative colitis. But please remember that it may be involved, but generally it is spared.